The blood pressure target your doctor is chasing right now was designed for a 45-year-old, not for you, not for your body, not for what happens inside aging blood vessels after decades of living. And if you are over 70, that number on your chart, the one your doctor celebrates when you hit it, might not be protecting you. For some of you watching right now, it could be doing the exact opposite. Think about that for a moment. Because right now, across this country, millions of older adults are being chased down to 120 over 80. Medications are being added, doses are being increased, and nobody is asking the question that actually matters. Is this target right for this person at this ass age with this body? I have spent decades in practice treating patients over 60, and what I have seen again and again is this. The system is treating a number, but you are not a number. You are a person. And those two things require completely different approaches. In this video, I am going to show you exactly why the standard blood pressure target can become dangerous as you age. I am going to walk you through the real physiology of what happens to blood vessels after 70. I am going to tell you about a specific patient pattern that changed how I think about this completely. And I am going to give you the precise conversation to have at your very next appointment. Before going any further, I have one question for you. Has a doctor ever sat down with you and explained why your specific blood pressure target was chosen for you? Not for populations, not for guideline tables, for you specifically. Type yes or no in the comments right now. I read every single one, and the answers always tell me something important. Now, let me start with something most people get completely wrong. Most people believe blood pressure works like a simple dial. Turn it up, bad things happen. Turn it down, good things happen. And when you are 40 or 50, that model is roughly correct. But here is what nobody tells you. Once you move into your 70s and 80s, that model breaks down. And the medical system has been slow to catch up. Not because doctors are bad, but because the system gives your doctor 7 minutes. 7 minutes to review your chart, answer your questions, manage your prescriptions, and send you on your way. 7 minutes is not enough time to explain what I am about to explain to you right now. So let me give you what that appointment cannot. Here is what is actually happening inside your blood vessels right now. Think of your circulatory system like a major highway. When you are young, that highway has wide lanes, smooth pavement, flexible on-ramps, and vehicles that merge and adjust speed effortlessly. Your circulation adapts instantly. Stand up fast, no problem. Get too hot, no problem. Miss a meal, no problem. Your blood vessels read those changes and respond in seconds. But here's what changes as you age. That highway gets stiffer. The lanes narrow in places. The merge ramps do not function as fluidly. Traffic backs up. And this happens to nearly every person past 65. Not because of anything you did wrong, but because of the biology of aging itself. Your blood vessels are lined with a specialized tissue called the endothelium. When you are young, this lining is extraordinarily flexible. It expands when more blood flow is needed. It contracts to redirect flow. It releases compounds that keep blood moving smoothly. It is arguably the most active tissue in your entire body. But over time, this lining loses some of that flexibility. The vessels themselves become stiffer. They calcify slightly. They lose the elasticity that allowed them to adapt moment to moment. And there is something critically important about this. That stiffness does push blood pressure higher naturally. Your heart has to work harder to push blood through vessels that bend less easily. And yes, chronically elevated pressure does damage organs over years. But here is the other side of that coin. The one your guideline does not account for. Because your vessels are stiffer, your body becomes slower at adjusting blood pressure from moment to moment. This is where it gets really interesting. And this is the part most people miss entirely. When you were 40, standing up from the sofa triggered an immediate response from your circulation. Your vessels constricted slightly to keep blood flowing to your brain. Your heart rate adjusted. The whole system compensated in a fraction of a second. You never felt a thing. But when vessels have lost flexibility, that response is slower, sometimes significantly slower. And in that gap, between the moment you stand and the moment your circulation catches up, your blood pressure drops, sometimes dramatically. Doctors call this orthostatic hypotension, but what it really means for your daily life is this. You get out of bed in the morning, and for a moment, the room tilts. You stand up from your chair after dinner, and your vision blurs briefly around the edges. You step out of a hot shower, and there is that peculiar moment where your body feels like it has not quite caught up yet. That is not just part of getting older. That is your pressure regulation system struggling to keep pace with the demands of gravity. And here is where the danger enters. If blood pressure medication is then piled on top of that already slower system, what is a minor inconvenience for a younger patient can become a genuine emergency for an older one. Because in a 40-year-old, that dizzy moment means grabbing a wall for a second. In a 75-year-old, that same moment means a fall. And a fall at 75 means a fractured hip, a head injury, an emergency room, months of rehabilitation. And for someone who lives alone, it can mean something far worse. Pay close attention to this number. A 2022 analysis published in JAMA Internal Medicine examined data from over 15,000 adults over the age of 70. It found that in patients with moderate frailty, aggressive blood pressure lowering increased serious fall risk by 31%. 31%. That is not a rounding error. That is a clinical signal that the guidelines have not adequately incorporated. 31%. Let that sink in. And here is the critical context that makes this even more striking. The major trials that established the current blood pressure targets, they largely excluded the frailer, older adults, people in their 80s, people on multiple medications, people with significant balance problems, people in care facilities. In other words, the exact group now most aggressively treated. So the targets come from data on one population and are being applied to a completely different population. And the system does not flag this for your doctor in a 7-minute appointment. Now, I need to be crystal clear about something. Nothing in this video is suggesting that high blood pressure does not matter. It absolutely does. Untreated high blood pressure silently damages blood vessels over years. It raises stroke risk, heart attack risk, kidney disease risk. The decision to treat is, in most cases, the right one. I am not here to tell you to distrust your doctor or abandon your prescription. What I am here to do is something much more specific. I am here to help you understand that the target matters as much as the treatment, and that target may need to be different for you than the guideline written for a population that does not look like you. Let me tell you about Sandra. She is 67 years old, retired postal worker from Virginia, 30 years on her feet every single day. She is strong in the way that only people who have worked physical jobs their whole lives are strong. Not delicate, not frail. She walks her neighborhood every morning. She tends a garden. She does not describe herself as an old person. Her blood pressure readings in the clinic were running around 165/88, high enough to prompt treatment. Her doctor, following guidelines, prescribed a standard medication at a standard dose. Within 3 hours of her first tablet, Sandra's blood pressure dropped to 92/56. She caught herself on her kitchen counter, hands braced, heart pounding. The floor felt like it was moving. She did not fall. She was lucky. But she called her daughter from that spot on the kitchen floor, hands still gripping the counter, voice quiet and shaking. She said, "I thought I was going to die. Now, here's what I want you to understand about Sandra's story." The medication was not wrong. The intention was not wrong. But the same tablet at the same dose given to a 67-year-old body versus a 45-year-old body can produce completely different results. Because Sandra's vessels, for all her strength and activity, had that natural stiffening that comes with age. Her regulatory system was slower, and the medication pushed past the threshold her body could compensate for. Her story represents a pattern I have seen repeatedly in practice. And it is a pattern the 7-minute appointment does not have time to prevent. Now here's the part that worries me most. Because Sandra's situation is not unusual. And most of the time, people do not catch themselves on the counter. They fall. And then the fall becomes the problem, not the blood pressure that caused it. If this information is connecting with something you have wondered about, hit like right now. The algorithm uses that signal to show this video to other seniors who need this conversation. It costs you nothing, but it could genuinely help someone. Now let me take you deeper into the science, because understanding the mechanism is what turns information into protection. Here's what I need you to understand before going any further. Your blood pressure is not a single fixed number. It is a dynamic system that changes hundreds of times every day. It goes up when you stand. It goes down when you sit. It responds to temperature, to what you ate, to your emotional state, to the time of day. What your doctor sees in the clinic is a snapshot, one frame of a movie that is constantly running. And here is where most people get it wrong. The number your doctor sees in the clinic, that is almost always your blood pressure at its most controlled. You have been sitting. You are probably slightly nervous. The reading is taken in a comfortable chair, in a temperature-controlled room, after you have been still for a few minutes. What that reading does not capture is what happens when you stand up in the middle of the night, when you climb stairs carrying groceries, when you are dehydrated on a hot afternoon, when you have skipped a meal, when you have just finished physical therapy. Those are the moments that matter. And those are the moments where the gap between your medication dose and what your body actually needs can become dangerous. Now, I want to walk you through the 3 most common mistakes in blood pressure management for older adults. These are not mistakes any individual doctor is making. They are built into the system itself. And knowing them is how you protect yourself. Mistake number 1. Treating the number in the chair instead of the person walking around. Standard blood pressure measurement is taken sitting down after several minutes of rest. This is a useful measure, but it is not the full picture. The measure that matters more for fall risk is the difference between your sitting blood pressure and your standing blood pressure. That difference is called orthostatic drop, and in older adults, it is critically under-monitored. Here is how this plays out in practice. Someone comes in with a sitting pressure of 160/90. Guidelines say treat. Medication is prescribed. The next visit, sitting pressure is 130/80. Numbers look good, but nobody checked what happens when that same person stands up. And when they stand up, their pressure drops to 100/65 every single morning, every time they get up from the sofa, every time they use the bathroom at night. That is orthostatic hypotension. And in a 2021 study published in Hypertension, the Journal of the American Heart Association, researchers found that orthostatic hypotension in adults over 65 was associated with a 48% increased risk of serious fall-related injury. 48%. From an issue that takes 30 additional seconds to measure and is not routinely checked, here is the specific thing I want you to do with this. At your next appointment, ask your doctor to check your blood pressure both sitting and standing. First, sitting. Then, stand up and have them check again within 2 minutes. If there is a drop of more than 20 millimeters of mercury on the top number, that is clinical information. That changes how aggressively your target should be pursued. Sandra had this done after her kitchen counter incident. Her sitting pressure was 158. Her standing pressure was 118, a 40-point drop in 2 minutes. And she had been on the dose that almost put her on the floor. Let me come back to Sandra in a moment, because what happened next in her story is something I want you to hear. Mistake number 2. Using the same target for a 75-year-old as for a 45-year-old. Here's what most people do not know about where the guideline numbers come from. The landmark trials that set 120/80 as the gold standard, the S-Print trial being the most frequently cited, were conducted primarily on adults averaging around 68 years old. That sounds elderly, but the average age hides the distribution. Participants skewed healthier than typical patients in that age range. People with significant frailty were excluded. People with dementia were excluded. People on complex medication regimens were underrepresented. In other words, these trials told us what happens when you aggressively lower blood pressure in relatively healthy 60-something adults. They told us much less about what happens in adults who are 80, frail, cognitively declining, or on multiple medications. And the guidelines that came from those trials were applied across all those groups. This is not a scandal. This is how medical research works. You design a clean study with a clean population. You get clean data. Then the data gets generalized to a messier real world. And sometimes the generalization fits, and sometimes it does not. For blood pressure targets in the oldest and frailer adults, the evidence is increasingly suggesting it does not. A 2019 consensus statement from the American Geriatric Society noted that for adults over 80 with multiple health conditions, the evidence supporting aggressive targets is weak, and the potential for harm, including falls, dizziness, kidney impairment, and fatigue, is real. The statement recommended that targets be individualized, based on frailty, based on fall risk, based on medication tolerance, based on what matters to the patient. Individualized. That word is doing enormous work because individualized care requires time, and time is what the system does not provide. Now, there is a second, subtler problem inside mistake number 2, and this one surprises most people when I explain it. Here is what I need you to really hear. Your brain may actually need a slightly higher blood pressure than it did at 40, not because high pressure is good for the brain. It is not. But because the vessels supplying your brain have adapted over decades to receiving blood at a certain pressure. And when that pressure drops too quickly, too aggressively, the brain does not always get enough. There is a process called cerebral autoregulation. Your brain is very good at protecting its own blood supply. When systemic pressure drops slightly, the brain dilates its small vessels to pull in more blood. When pressure rises, those vessels constrict slightly. But here's the thing. That autoregulation has a range, a window it operates within. And that window can shift upward as you age, particularly if you have had chronically elevated pressure for years. If your blood pressure has been 160 to 170 for the past decade, your brain has adapted to that level. It has recalibrated what normal looks like. And if medication rapidly brings you down to 120, your cerebral autoregulation may not be able to compensate fully, especially in the very vessels that have stiffened with age. This can show up as brain fog, as fatigue, as confusion, as a kind of flatness that you might describe as not feeling like yourself. And here is the heartbreaking part. Those symptoms are often attributed to aging, or depression, or just what it feels like to get older, not to the medication that might be pushing the brain below its optimal perfusion pressure. I have seen patients become measurably sharper, more present, more engaged, when their blood pressure target was revised upward by 15 or 20 points, not because they were healthier at the higher pressure, but because their brains were getting the flow they needed. Now let me get back to Sandra, because something happened in her 3rd week on the revised protocol that I want you to know about. After the kitchen counter incident, her physician adjusted the approach. Slower titration, a different medication class, blood pressure checked sitting and standing, and the target was revised from below 130 to below 145, 145, not 120, not even 130. Sandra's daughter called the office 3 weeks later. She said, "She is not the same person she was a month ago. She is making jokes again. She got back in the garden." Sandra herself came in for her follow-up. Her pressure was sitting at 142 over 80. Standing, it was 131, a manageable 11-point drop. She looked directly at the doctor and said, "This is the first time in 2 months I have not been afraid to walk to the bathroom at night." That sentence, that is what this is all about. Not a chart, not a guideline. A person who was afraid to walk to her own bathroom. Mistake number 3. Overlooking what the medications themselves are doing at this age. This is the part of the conversation that rarely happens in a 7-minute appointment, and it is one of the most important. As you age, your body processes medications differently. Your kidneys are less efficient at clearing drugs from your system. Your liver metabolizes compounds more slowly. You have less body water as a percentage, which affects how drugs distribute. And you are often taking multiple medications that interact with each other in ways that no single study has fully mapped. Blood pressure medications in particular have age-specific effects that deserve attention. Bear with me for 60 seconds here, because what comes next will change how you think about your prescription bottle. Diuretics, which include medications like hydrochlorothiazide and furosemide, work by pulling fluid from your circulation. In a younger patient, this is usually well tolerated, but in an older adult, it can accelerate dehydration. And dehydration in people over 70 is not just about feeling thirsty. It affects kidney function. It affects electrolyte balance. It affects the blood pressure regulation system itself. And it can create a cycle where the medication causes dehydration, dehydration makes blood pressure harder to control, and the dose gets increased to compensate. I have seen this cycle more times than I can count. Calcium channel blockers, including amlodipine and diltiazem, can cause significant ankle swelling in older adults. That swelling is sometimes treated as a new problem, a new diagnosis, new medication, when the real answer is to evaluate whether the original drug is appropriate. ACE inhibitors can cause a dry, persistent cough, not in everyone, but in a meaningful percentage of older adults. And that cough can go on for months, being attributed to allergies or reflux, or just being what happens when you get older, before someone connects it to the medication. Beta blockers can cause fatigue, real fatigue. The kind that makes you want to sit on the sofa instead of walking the neighborhood. And that fatigue gets called aging, gets called low mood, gets called a new problem that needs its own solution. Here is the single most important thing I will say in this section. Side effects in older adults are not always dramatic. They are often subtle. They are often gradual. And they are often attributed to age rather than medication, which is exactly why you need to be specific with your doctor about what you are experiencing. Not just, I feel a bit off. That will not get you very far. But I have had swelling in my ankles since I started this medication. That changes the conversation. Or, I have had a dry cough for 3 months, and it started 2 weeks after my dose was increased. That changes the conversation. Or, I have been exhausted in a way that feels different from being tired. It started after the new prescription. That changes the conversation. Specific, observable, connected to a timeline. That is what gets heard in a 7-minute appointment. Now, here is where I want to shift the conversation from problems to something more useful. Because everything I have said so far has a purpose. Understanding the mechanism is not just interesting, it is protective. When you understand why these things happen, you can participate in your own care in a completely different way. And that participation can change outcomes. So let me give you a practical framework. Not just what to know, but what to do. Step 1. Know your numbers beyond the one in the chart. Your doctor sees your sitting blood pressure. You need to know 4 more numbers. Your standing blood pressure measured 2 minutes after standing. I explained why. And a 20+ point drop on the top number is your signal to have a specific conversation. Your blood pressure first thing in the morning before any medication. This is often when it is highest and is genuinely useful information. A consistent reading above 175 on the top number, morning after morning, tells a different story than an occasional spike. Your blood pressure in the evening, 3 to 4 hours after medication. This shows you whether the medication is maintaining effect or wearing off early. Significant variation tells you something about timing and dose. And finally, your blood pressure when you have symptoms, when you feel dizzy, foggy, or unsteady. That reading, taken in the moment, is invaluable information. It connects sensation to physiology in a way that a clinic measurement cannot. Now, here is something important. You do not need a doctor's office to get these readings. Home blood pressure monitors accurate enough for clinical use are available for under $40, validated ones. And the American Heart Association has published guidance confirming that home monitoring is not only acceptable but recommended for older adults managing blood pressure. The guidance is available at heart.org. Here is the specific protocol I recommend to patients. Take your blood pressure every morning for 2 weeks at the same time, before medication, before coffee, after sitting quietly for 5 minutes. Write it down, every single one. Bring that log to your appointment. That 2-week log gives your doctor more information than 20 years of individual clinic readings. Step 2. Have a different conversation with your doctor. Not, how is my blood pressure? That question gets a chart answer. Instead, is my current blood pressure target appropriate for my specific age and health situation, given what I now know about how targets were developed? Is it time to review whether the benefit of this specific number still outweighs the risk of pursuing it in my body? And then, has my standing blood pressure been checked recently? I would like to know how much it drops when I go from sitting to standing. And then, I have been experiencing this specific symptom since starting or increasing this medication. I want to understand whether it could be related. Those 3 lines of questioning, in that order, give your doctor everything they need to have a genuinely individualized conversation with you. They signal that you understand the context. They make it easy for your doctor to engage meaningfully. And they shift the dynamic from patient being treated to patient participating in care. This is not being difficult. This is not doubting your doctor. This is exactly what informed patients are supposed to do. A good physician welcomes this. Because you are providing information the system does not otherwise give them time to collect. Step 3. Understand what individualized care actually looks like for your age. Here is the real answer to the question, what should my blood pressure be? It depends. And anyone who tells you otherwise is giving you a guideline, not an answer. But here is what the evidence actually supports. If you are over 65, otherwise reasonably fit, active, not experiencing significant falls or dizziness, and tolerating your medication, well, aiming for below 140 on the top number is a reasonable and evidence-supported target. sometimes closer to 130 if your kidneys and overall health support it. If you are over 75 with moderate frailty, multiple health conditions, significant fall risk, or you are experiencing symptoms with your current regimen, a higher target, perhaps 140 to 150, may genuinely serve you better. The American Geriatric Society has suggested targets up to 150 over 90 for this group. If you are over 80, the evidence for aggressive targets is genuinely thin, and the potential for harm from falls, kidney effects, and medication burden is meaningfully higher. A conservative, symptom-guided approach often makes more sense than aggressively chasing a number. None of these ranges is a prescription. They are conversation starters. The point is that there is no universal right answer. There is only the right answer for you. Now let me tell you what happened with Sandra in the months after her care was revised. She came back 6 weeks later for her follow-up. Sitting pressure was 144 over 82. Standing was 133. An 11-point drop. Well, within a manageable range. But what her physician noticed most was something that does not show up on a chart. She walked in differently. She was not navigating the waiting room with that careful, slightly uncertain quality that had appeared in her gait since starting the first medication. She moved like herself, and she had brought something with her. A little blue notebook, 2 weeks of blood pressure readings taken every morning at 7:15 before her coffee. 141, 139, 144, 138, day after day, consistent, predictable, controlled. She set it on the table and said, "I did the homework." That notebook, that 2-week log, that changed how her care was managed from that point forward, because it showed her pressure was stable without the aggressive medication that had nearly put her on the floor. It showed the revised target was working, and it gave her a sense of being in the room, not just as a patient receiving decisions, but as a participant making them. That is what I want for every person watching this video. Now let me address the question. I know some of you are asking, what if my doctor pushes back? What if they say the guideline is the guideline and my numbers need to be lower? This is a legitimate concern, and here is how to approach it. You are not asking your doctor to be wrong. You are asking them to individualize. Those are different requests. You might say, I understand the guideline recommends below 140. I also know that I am experiencing dizziness when I stand, and that studies in adults my age have raised concerns about aggressive targets in people with that symptom. Can you help me understand what the right balance looks like for my situation? That framing gives your doctor room to engage. It shows respect for the guideline while introducing the clinical context that individualization requires. Most physicians, when approached this way, will engage thoughtfully. And if they do not, if the response is simply, "This is the number," end of discussion, that is information too. Information about whether this particular clinical relationship is giving you the individualized care that your age and situation require. You are allowed to advocate for yourself. That is not confrontational. That is participating in your own health. Step 4. Know what to watch for and when to act immediately. This is the practical safety net. If you have made any changes to your blood pressure management, whether a new medication, a dose change, or a revised target, there are specific things to monitor in the first 2 to 4 weeks. Dizziness when standing that is new or significantly worse than before. This is your signal to measure your standing blood pressure and report it promptly. Do not wait for the next scheduled appointment. Fatigue that is different from your normal baseline. Not just tired, but a new quality of tiredness. Heavier, more persistent. That is worth a phone call. Confusion or foggy thinking that has changed. If you or someone close to you notices that you are sharper at some times than others, and the clearer times tend to be when your blood pressure is naturally a bit higher, that is clinically relevant. Cramps, muscle weakness, or unusual thirst. These can indicate electrolyte changes, particularly from diuretics. Low potassium, in particular, can be a real concern in older adults on these medications. And this one is non-negotiable. If you feel faint, your vision goes dark, or you actually fall, that is an emergency. Not a wait and see. Not a log it for the next appointment. Call your doctor the same day. Or, if it is severe, call for help immediately. I almost forgot to mention this, and it is important. Dehydration is one of the most underappreciated amplifiers of blood pressure medication risk in older adults. Even mild dehydration, the kind you might not even notice, can cause blood pressure to drop more dramatically when you are on medication. Because medication is reducing your systemic pressure and dehydration is reducing your blood volume. Those two things together can push your standing pressure into dangerous territory very quickly on hot days, after exercise, after an illness, after a procedure that required fasting. These are high-risk windows, and being aware of them, keeping yourself well hydrated on those days specifically, is a practical safety measure that takes almost no effort. Here is the specific guidance on hydration. In older adults, thirst is not a reliable signal. Your thirst mechanism becomes less sensitive as you age, so you can be meaningfully dehydrated before you feel thirsty. The simple target, 6 to 8 8-ounce glasses of water or other non-caffeinated fluids daily, remains the best baseline. But on high-risk days, consider an extra glass or two. And if you are on a diuretic, talk to your doctor about what your specific target should be. Now I want to talk about what to expect if your doctor does revise your target or your medication, because this is where people stumble, not from lack of information, but from lack of preparation. Week 1. Your blood pressure readings will almost certainly go up, sometimes significantly. This is normal, expected, and it does not mean the change was wrong. When you have been on an aggressive regimen for a while, your body adapts to suppressed pressure. When that suppression is eased, your pressure rises to find a new equilibrium. That process takes time. And watching the numbers go up in week 1 feels alarming when you have been conditioned to think that lower is always safer. It is not always. Not for you. Not at your age. Do not panic in week 1. And do not go back to the old dose on your own. Give the revised plan the time it needs. Week 2. Energy often improves before the numbers settle. Many patients notice this, and it confuses them. They feel better, but their pressure is higher than before, and they wonder if something is wrong. Nothing is wrong. What you are feeling, that return of energy, that improvement in mental clarity, that sense of being more yourself, is your brain and body operating with better perfusion, with blood flow that is more appropriate for where you actually are. Week 3. This is typically when stability begins to emerge. Readings start to be more consistent. The standing drop, if it was significant, often becomes more manageable. And any medication side effects that were present, swelling, fatigue, cough, have often begun to ease. This is the week most patients call in to say, I feel like I did 2 years ago. Week 4 and beyond. This is when the real picture becomes clear, when you can look at your home log and see a pattern, and when the conversation with your doctor shifts from adjustment to maintenance. Most people want a quick answer, a single number, a simple rule they can follow and be done. I understand that impulse. Uncertainty is uncomfortable, especially when it comes to something as central as your heart. But here is the truth. The blood pressure that protects one 70-year-old can make another one fall. The system you have been relying on to sort this out was built for populations, and you are not a population. You are a person. And the good news, the genuinely good news, is that individualized care is possible. It requires more conversation. It requires a home monitor and a 2-week log. It requires knowing the specific questions to ask. And it requires being willing to advocate for your own safety, even when that advocacy takes effort. You have already done the hardest part. You showed up today. You stayed. You listened to 30 minutes of information that your appointment has never had time to give you. And what you understand now, most people who see your doctor in that waiting room do not understand. You know that blood pressure targets were built on research that did not include your age group in adequate numbers. You know that orthostatic hypotension is a real, measurable, under-monitored risk. You know that your vessels behave differently now than they did at 45. And you know that the symptoms you have been dismissing as aging, the dizziness, the fatigue, the mental fog, might be telling you something about your medication that no one has taken the time to listen to. That knowledge is your protection. Now let me tell you how Sandra's story ends. 8 months after the kitchen counter incident. 8 months of revised target, different medication, standing blood pressure monitored, home log maintained. Her daughter came to the follow-up appointment with her, which she had stopped doing for a couple of years because Sandra had seemed fine and the appointments were routine. But this time her daughter came, and she said something that I want you to hear. She said, I got my mother back. Not because Sandra was cured of anything, not because her blood pressure was perfectly controlled by any guidelines definition, but because she was present, active, walking 2 miles in the morning, pulling weeds on her knees in the garden, laughing at the doctor's bad jokes. That is the outcome this conversation is designed to protect. Not a chart number, but a life. Now, I need to give you something specific to do before this video ends, because information without action is just interesting. And interesting does not keep you safe. Here is exactly what I want you to do. Before your next blood pressure appointment, write down one thing. Just one. The symptom you have been dismissing is aging. The dizziness when you stand. The fatigue that does not match how you used to feel. The foggy mornings. Write it down. Specifically. When it happens. How often. And what was different before. Then at the appointment, hand your doctor that paper. Or read it out. And say these exact words. I want to understand whether my current blood pressure target and medication are still appropriate for my age and my specific symptoms. And I want to know if my standing blood pressure has been checked recently. That is it. That is the whole conversation starter. 2 sentences. Specific. Non-confrontational. Informed. That conversation is worth more than any single medication adjustment because it changes the relationship from one where the system manages your number to one where you and your doctor are managing your health. Type "I finished" in the comments if you watch this all the way through. And then share this video with one person. One. Your spouse. Your sibling. Your friend who has been on blood pressure medication for years and has never had this conversation. You do not need to explain it. Just share the video and say, I thought you should see this. Because here is what I know about you. You would not still be here at minute 30 if you did not care. About your health. About being present. About not letting a 7-minute appointment decide something this important without understanding it first. That caring, that attention, that is the difference between a number being managed and a life being lived. But before you go, there is something I did not get to today. Something that connects directly to everything you just learned. There is one thing a significant number of older adults do every single morning that makes blood pressure harder to control and makes medication more dangerous. It has nothing to do with salt. Nothing to do with exercise. It is something that seems completely benign. Something no one questions. That is what I am covering in the next video. And if what I said today changed how you think about blood pressure, the next one is going to surprise you even more. Take care of yourselves, and I will see you in the next one.